the purpose of this interaction is to initiate a relationship with Musero University and UHAS. We have MOU between the two universities, and we're going to start from next year, hopefully having students come to the university, and I'm sure one relationship will lead to the other. I'm very confident that the two topics that our guests will be talking, we're sharing their ideas on today. I'm sure we'll learn something from them. We're also hoping that along the line, faculty from UHAS will also be given the opportunity to have the same experience in the university in the US. I'm hopeful also that as we journey along, the relationship would grow beyond these seminars and student exchanges to other bigger research collaborations in the future. Looking at the time, we didn't start on time, so I would like to thank all those online. I see over 40 people online and those in person. Thank you very much for making time. And like I said, when we hosted Prof. Tobias, when you have collaborators, invite them and we would give them the opportunity to share their science with us. So on that note, thank you very much, Madam Director, and I wish that the program will be successful. Thank you.
Thank you, Prof. One. Now, I'd like to call upon the school officer, which is Mr. Solomon Akrong. He's an assistant registrar here at Binka School, and he will do us the honor of introducing the chairperson.
Thank you, Director. Our chairman for today's occasion is a physician scientist and a fellow of Royal Society of Medicine, and is also a nutritional epidemiologist. He is a fellow of the International Union of Nutritional Sciences, and currently he is a professor, an associate professor, and the dean of the School of Public Health of the University of Health and Allied Sciences. He is an expert in curriculum design, and he has interest in non-communicable diseases. Actually, his research areas tread through non-communicable diseases and a link between maternal health and intergenerational risk. He has served on many international boards, including Food and Agriculture Organization. Please join me to welcome Professor Paul Amuna, our chairman for today's occasion. Prof, you're welcome.
Thank you very much, Mr. Solomon Akron, School Officer, Binka School of Public Health. And the director, when she was introducing you, referred to you as an assistant registrar. I just want to correct that. Mr. Akron is a senior assistant registrar. That is, it's important for us to get the ranking very right. So, with all due apologies. So, it gives me great pleasure to be part of this. And as the Vice Chancellor mentioned, this is the second in a series of public lectures that the university has hosted so far this year. There will be many more. However, here at the Binka School of Public Health, this is about the 5th public lecture that we are hosting. Because we, in addition to the university's public lecture series also have some of our partners who work directly with us and visit us from time to time. And whenever they visit, we like them to share with us their experiences, their work, their research, and things like that. And so I'm sure we'll have more. I'm also particularly pleased to note that in addition to our August visitors from the University of Missouri, in the persons of Professors Carolyn Orbann and Wilson Majee, we also have here this week faculty and students from the Campbell University in North Carolina, and they are part of this seminar today. I think the topics that have been chosen are apt, as the Vice Chancellor mentioned, and I would not like to labor on, except to say that we are looking forward to a very exciting interaction, and hopefully we will leave here with some new thinking and ideas about how to go about things. I will take my seat now and then allow the program to go on, and then at the right time I'll come back in. So I want to thank Professor Carolyn Orbann and Professor Wilson Majee for making time to come here to the University of Health and Allied Sciences, and also to visit us here at the Binka School of Public Health. So thank you.
Okay, and so let me put on record my formal correction. Senior Assistant Registrar, my apologies. I'd like to call upon our registrar, Ms. Ya Amankwa Opuni. She's also online so that she can give us a few words of welcome, and then we'll proceed from there. Madam Registrar, you're on. Okay, I understand that she's not ready at this time. And so the acting dean of the Office of International Programs, in the person of Dr. Robert Kaba Al-Hassan, will introduce the first guest lecturer.
Director, can you hear me? Hello, Director.
I hear registrar in the background. Is the volume up for her?
Can you hear me? I can hear you. Can you hear me, please?
Not very clearly. We are working on that. Please go ahead. Proceed.
All right. So thank you for inviting me to say one or two words. We thank the School of Public Health. We thank the Office of International Programs for this initiative. Recently, we had one successful speaker in the at the whole campus, and we are pleased that we are having these two renowned speakers for today. And I welcome, let me add my voice also to the welcome address by the Vice Chancellor, to welcome all of you on the call, and say that we are most happy and delighted to have our guest speakers for today's program. Thank you.
Thank you, Registrar. Okay, so Dr. Kaba.
I may need some IT help here to do some projections. Something that works. Okay. Good afternoon. Good afternoon. Looks like the Banku is working. Those of us who took Banku. Yes. Prof Chair, faculty members here present, our invited speakers, our guest students, faculty members of SPH, now Fred Newton Binka School of Public Health, our UHAS students here present, the UHAS media team. Is UHAS TV here? I can see we are live. So it's a great opportunity to, and then an honor to introduce our speakers for today's public lecture. And as you would have heard from the Vice Chancellor's opening remarks, this is the second in the series that the Office of International Programs has initiated in the spirit of our internationalization agenda. UHAS is relatively young and small, but we are already covering grounds. So from this map, you would have realized that we are already all over the place on the globe. So as part of efforts to continue to reach out to the international community, the Office of International Programs, in collaboration with the Office of the Vice Chancellor, has started the public lecture series so that we can invite faculty members here, or individual faculty members can propose individuals who are astute in their areas of research to come and share some knowledge. So we started off with the first one that was held at the main campus, and this was by Professor Tobias Renke de Wit from the University of Amsterdam. And he delivered his lecture on From COVID to Digital Epidemic Preparedness in Africa. And then today, we are privileged to have our two august speakers from University of Missouri. One is going to be speaking on a comparison of the 1918 flu and COVID-19 in 4 Missouri counties. The other would focus more on developing a research and publication agenda. So can you imagine these packed topic areas? Now to my role for this afternoon, I'm to introduce the first speaker, and then subsequently the second speaker will be introduced by the incoming Dean of International Programs, Prof. Takan. So for Prof. Orbann, who is Prof. Carolyn Orbann, she is an associate teaching professor, and I get the feeling she wants to emphasize teaching. Yeah, because she's more into the teaching and then combines that with research. And fortunately for us, she is also the coordinator of international and intercultural initiatives. What it means is that we have the opportunity to already begin to strike deals as to what we can do going forward. So by way of her education, she is an anthropologist. If you look at her record, she is full-blood anthropologist by research, by way of doing things, right from the undergrad level all the way to the PhD. So she is an outstanding medical anthropologist for that matter. By way of her research interest, she is into cultural behavior and spread of infectious diseases in human populations, also into agent-based computer simulations, models, which I find interesting, population contact and cultural changes in times of epidemic diseases, and then, of course, historical epidemiology using primary source of records. So she's also been awarded with quite a number of prestigious awards. One, she was a recipient of the 2014 Writing Intensive Excellence Award. And then she also received the Department of Health Sciences Faculty of the Year Award 2020. I thought you would have clapped for her at this stage. By way of research, she is into several collaborations with research, has published in her area. So, ladies and gentlemen, I present to you Professor Carolyn Orbann, who is going to present on the topic, a comparison of the 2018 flu and COVID-19 in 4 Missouri counties, disease transmission and county characteristics. Ladies and gentlemen, let's welcome Prof. Carolyn Orbann.
Thank you. Thank you so much. I very much appreciate you inviting me to give this lecture.
while I'm here, visiting your country and your institution. I'm so glad to have been able to make this trip here at the end of our semester. We flew right off after graduation to come to visit you here. And so thank you to Wilson for inviting me to come along, and thank you to you and your school and your university for hosting me. I am going to talk about my research, but I'm going to spend the first part of my talk on my research and the second part on how I've included undergraduate students in that research, because the achievements that I've had in this project would not have happened if I hadn't had access to willing and able and enthusiastic undergraduate research assistants. So I'm really excited to be able to do that. All right, you'll notice I've changed the title slightly, and that's totally on me. When I originally gave this talk, a version of this talk, I did only have results from 4 counties. Missouri, my home state, has 115 counties, and I can tell you now at this point, we actually have results from all of them. So I'm actually going to give you some better, comprehensive results than I originally planned. So I started this project on 1918 flu in my state before the COVID pandemic. I actually started it at the end of 2017, just because I found some data that looked interesting. I'm a flu researcher in my own research time, and I wanted to address some questions I had about the pandemic in our state. However, then COVID happened, and people became interested in 1918 flu. Before COVID, there was a group of interested researchers, but I wouldn't say that people were interested at the level that they are today. So early in 2020, May 2020-ish, we actually got funding from the National Science Foundation on an emergency funding source to compare the 1918 flu with COVID outcomes as the pandemic was progressing in our state. And so that's what enabled us to really push this project to completion. And so what we are interested in our state is to look at the differences between populations in urban places and rural places, because Missouri is a state of extremes. For those of you that don't know Missouri, I'll show you where it is, I'll tell you a little bit about it. But it is a place of extremes, and we have some very extremely rural people and places in our state, and we have some highly urbanized populations. And we wanted to understand what the patterns of transmission between those were. Was there some predictable pattern between these two pandemics that we could identify about the way the disease spread? And were there some populations that increased risk of the pandemic, either based on rurality or on their urban condition? So that's mostly what we were doing. These just are from our grant proposal, the kinds of things we were doing. So we were comparing patterns of illness and death, and when we say patterns, we mean geographic spread, we mean timing, we mean severity. I don't have case data from 1918 flu. As you can imagine, good data on 1918 flu is pretty limited, and so I'm limited to mortality. So we were comparing flu mortality with COVID mortality. We also were able to put in COVID case data. So we had COVID case data as well. To do that, one of the things we had to do was a kind of a historical dive into what each place in Missouri was like. And so we used a lot of archival resources, we used census documents, we did use some secondary sources on the socioeconomic status of people in various counties, the education level, the racial and ethnic diversity, the wealth, the common industry, that kind of thing. I worked with a diverse team. There were 2 anthropologists as co-PIs, but we also had a statistician, we had an engineer, we had a microbiologist or a he's in med micro, and we had somebody from family medicine. So we had a pretty diverse research team on this project, in addition to several graduate students and many undergraduate students. So we started by trying to kind of assess the characteristics of different counties to see, if we could group them, because 115 counties, we couldn't consider them individually in our results. We wanted to find groupings of counties that were similar to each other, not just based on geography, but also based on shared attributes. So that's where we started. So this may be old news to people at this point, but have you heard of 1918 flu? Sometimes it's called Spanish flu. What do we know about it? We know that it was a pretty deadly disease. Every country had its own pattern, but there were some general international patterns as well. The estimates vary widely on how many people exactly died in this flu. Maybe 50 million, maybe more, maybe less. The mortality rate, as you can see on the slide here, it depends on the location, somewhere in the range of 2.5 to 5% case fatality rate, which means, if you got it, were you going to die, as opposed to overall mortality. But it was much higher in some places. The highest mortality location in the world, I believe, was in Labrador in Canada, which it killed an entire village. Yeah, the spread was, it's local, but the patterns seem to be driven by population movements, like a lot of human diseases, and can be connected in some places to the winding down of World War I, when you had troop movements home. In the US, it's also connected to us entering the war, because we entered so late, and we're moving people around in our country quite a bit during that time. The reason that 1918 flu is particularly notable, aside from it being a much more deadly flu than normal, was its irregular age distribution of mortality. So a typical flu kills people at either end of their age range. It kills the very young and it kills the very old. This particular flu had an increased mortality peak in midlife. So we say a typical flu has a U-shaped mortality curve. This flu has a W-shaped mortality curve. And you can see that on that slide there. The 1918 flu is typically thought of as occurring in 3 waves. A mild spring wave in 1918, where it spread quite a bit but didn't kill that many people. A very severe fall wave, and then what they used to call, the 1919 wave. They used to call it the last wave, but I'll tell you why I think that's a bad idea, in the spring of 1919. So in Missouri, this is our curve. I collected the death data from death certificates filed at the state level. I collected a 3-year period, so 1918 through the end of 1920. And what you're seeing here is our pattern. We have this spring wave, looks like at the end of a typical flu season to me. It's not an increased mortality, it is a little bit longer. So it's a little bit longer. Here's our fall wave. It starts in October. This is mortality. It starts in October. You have another peak there in December, and then you have kind of a slow tapering off over the spring. So we're kind of missing that 3rd wave that people normally see. And you may say, well, what is this? This is all the way into February 1920. So now we're starting to advocate for saying not the 1918 flu, but the 1918 through 20 flu, because it actually lasted much longer than we think. What did I want to say about that? Many of the death certificates that are recorded in this pandemic don't say flu on them, or they say flu is a contributing cause. That's very common. Most people who died in this pandemic died of pneumonia. And so you'll see that in many of the death records. So COVID, now we all have become COVID experts out of the last 3 years, yeah? We all know what COVID is. It's another respiratory disease. The global mortality, I checked the numbers yesterday, are reaching close to 7 million people around the world have died. US mortality is 1.125 million. So it's very high. These images here are from earlier in the pandemic. So this is from the early strain that killed disproportionately older people. And you can see how quickly it spread over the course of a few months. This rivals the spread of flu during that World War I period, likely because of travel, how quickly we can travel now. So we had, just about worldwide distribution in a matter of months. And just in case you like things in table form, to compare these two, one of the things that we often have to do is, especially in COVID, people are saying, well, it's not like the flu. And it's not as bad as 1918 flu, but it shouldn't be. It's 100 years later, and we have much better health care. We have much better public health, but it is still a severe cause of mortality and illness. Okay. All right. And just keep in mind, the caveat here is that the flu deaths here were over the it should be end of 3 years. So they were counted from 1918, 19, and 20, while the estimates for COVID are for the entire course of the pandemic. So why did we think that we should do this? Why should we compare 1918 flu to COVID? They're 2 different diseases. They're from different, viral sources. They aren't really the same. My co-PI and I, my dissertation advisor, Dr. Lisa Sattenspiel, we're interested in human behavior. These are both respiratory diseases, and respiratory diseases, are spread by certain kinds of human behavior. And so we thought that they might actually be comparable, even though biologically they're not that similar. And so the things that drive spread in human communities of COVID are going to be the similar things that drive spread of flu. And so we thought, okay, you know, there's droplet transmission, the whole argument about COVID and whether it's aerosol, we're not that concerned about that. But we know that there's spread. We know that it's spreading through human populations. We know that there are people in our communities that have different levels of risk because of things like housing, because of things in our country like insurance and access to medical care. And those things are persistent over time. And I'll show you, Missouri is actually remarkably similar to how it was in 1918. There are some things that make it a good study site. Okay. And also the NPIs, especially early in the COVID pandemic, before we had vaccines, before we had targeted treatments, the only thing you could do for COVID was the same things that you could do for 1918 flu. Masking, distancing, hand washing, ventilation, all those things still work, right? Whether it's COVID or flu. Just another illustration of how they're different. Here's the 1918 flu mortality curve versus this is the 2020 COVID mortality curve. This has changed a little bit with the new strains. But the age distribution of death is probably the thing that's most different about them between these two diseases. So I just want to make sure that that is noted. Also, COVID, especially now, the current strains tend to spread much more quickly than flu does. So what are the other differences? You know, I said our human behavior, it doesn't hold the same over time. There are similarities over time. So we know things that are different include technological changes in how we can treat, technological changes in medicine, the faster development of new treatments and vaccines. Back in 1918, viruses weren't even really known. They didn't really fully understand what a virus was. They didn't understand the strain structures of different flu strains. They didn't have vaccines for flus. They actually started trying to develop vaccines for flus, but they were trying to develop them for bacteria that they thought caused the flu. So they were kind of running down the wrong path. And also faster dissemination of information. Does anyone remember how fast they had the genomic sequencing of COVID once it was identified? Something like 6 weeks. So they could start vaccine development 6 weeks after the first cases were kind of the source was identified. So this is an amazing difference between then and now. Also, the kinds of institutions that played a role. We know that social institutions are always important for disease spread, but the exact type are quite different. Back in 1918, you had things like asylums, residential schools, orphanages, factories. Now you have the centers of spread happening in congregate living, like assisted living homes, or in meat processing plants and in jails and prisons. So these social institutions are always important, but we have to think about which exact ones are the places of spread. So I realize I'm not in the US, so maybe I need to tell you where Missouri is in our country. Even in the US, sometimes I have to tell people where Missouri is. We are right in the center of the country, the actual center, the geographic center, the population center, statistically, of our country. We're not a very big state. Our landmass is a reasonable size, but we're about 6 million people. What I did is looked at the 1910 census to try to get a handle on what the population was like back in 1910. It was about 3.2 million, 3.3 million. It was, roughly even male and female, and here you can see it was still predominantly rural, slightly, 57% rural. In 2020, we're now at 6 million, still about 50-50, but we're 70% urban. So we have urbanized as a state. Our rural populations have actually, our rural places have emptied out a lot. A lot of cities have disappeared, small towns, and some towns have lost in the 100 years about 50% of their population. We use the variables literacy rate to get a proxy on education. The variables that we used to build our county structures we had to get from the 1910 census and the 2010 census. And so we had to find variables that we could track over that 100-year period. So literacy is our education proxy. You can see it's actually gone down. But one of the reasons was back in 1910, literacy was only counted under white males. So they only were recording in a certain population. You can see that we've become a more racially diverse population as well, but we're still not that racially diverse. we've gotten more diverse, but not by much. So here's the map of the state. Just to compare 1910 and 2010, our population centers are essentially the same. So while we've urbanized into the same places. There haven't really been any new urban centers that have come about. So you have Kansas City on the left side, St. Louis on the right. Those are our two main cities. You have the area down here, which is Springfield and Joplin, which at the time were mining. They were mining centers. And then right in the center, you'll see that's the only new urban place, which is where my university is in the city of Columbia and our state capital, Jefferson City. It's kind of a conglomerate. So this is part of the reason we thought it would be interesting to look at these, because our population is distributed similarly. The main modes of travel are similar. The same state highways and national highways connect the cities in the same way that they did back then. And so we thought it might be a good model. Okay, so I talked about this already. This is our just the number of deaths across that period. And so you just have quite a lot of deaths. And what we wanted to do was understand if these deaths, if you decompose them into rural places and urban places, or north and south, or east and west, were there any differences to this pattern, especially the timing pattern? Because I was very interested to understand if we could tell which direction the flu came in, or which direction it spread. Was it spreading from cities to rural, or was it spreading the other way, or was it spreading from Chicago down? Lots of questions. So what we did is we used those socioeconomic variables to establish clusters. And so here's our clusters. So instead of just drawing lines around geography, we had our statistician and his graduate students use a statistical method to use the socioeconomic indicators, and they came up with these clusters. And you'll notice that they're not geographically contiguous. These are just counties that are more similar to each other than they are to counties that are around them. So we came up with 4 clusters. The interesting thing about to me is the yellow cluster. The yellow cluster contains the cities. We called it central because it is largely central, but it contains the 2 cities at the bottom, and it contains another moderately sized city on the north side of the state, on the northwest side of the state. When we looked at the deaths in those clusters, we found some interesting patterns, and that is the southeast and the central cluster all had higher mortality over time, and they stuck together. So the southeast and the central. The southwest and the north cluster had their own pattern with relatively lower mortality over time. And so to you, that may not mean anything if you don't know much about the state, but what we know about the state is that the yellow cluster holds all the urban places, which in 1910 had a lot of health risks in them. Missouri's urban places were a place of factories, a place of kind of very close living quarters, a lot of poverty, a lot of exposure to environmental toxins. And the southeast is the place that even today is the poorest part of the state. It was the poorest part of the state back then, and it even still is today. So that made a certain amount of sense. If you look at COVID, here's Missouri's COVID pattern. This is just numbers of deaths. So these are just numbers because I wanted to hold it similar to the flu. You can see that we had a number of waves. We had a pretty tough winter, and then we had another pretty tough winter in 2020 to 2021, and then 2022. You'll see that I believe now the majority of Missouri's deaths happened post-vaccine deployment, if you look at all those numbers. We have quite a bit of vaccine resistance in our state. So when we did the cluster analysis, it did not identify the same clusters. So there have been differences over time in these counties. And you'll notice that the south area of the state is no longer split into 2 on an east-west. Instead, the Boot Heel comes out as its own cluster. And this is the area where there is the highest amount of socioeconomic need, the kind of most severe generational poverty, lack of educational outcomes, and lack of access to health care. So it came out into its own, and then the south kind of took on its own. Then the urban counties also kind of came out into their own cluster. So that just shows that pattern of urbanization in the state over time. And what you see here is that the COVID mortality, in this case, you see the Boot Heel is the area of the highest mortality. So this tells us that those indicators we were seeing all the way back in 1918 have persisted over 100 years of time, so that now they are almost uniquely at risk of death, of mortality during the COVID pandemic. And we wouldn't have necessarily predicted that, from 1918, but you can see it in the data. And the problem with this is the state has a history of trying to do intervention in this area. This is not a secret. People know that this is an area of high need, and they've tried to put resources towards it, but the resources haven't been effective. They haven't been effective. So as I'm kind of showing you my project, and believe me, I could talk about this all day, but for your sake and mine, I won't. I want to just highlight what students have done to work with me on this project. I actually started this project, as I said, before COVID, and the reason I started it was that I had a scholar who is part of a special scholarship program at our school called the Ronald McNair Scholars. This is a funded program for undergraduates starting in their junior year. They can do a junior or senior, and they get paid to do research with a faculty member, to have a mentor. And so the student I had really wanted to do something with mortality data. She wanted to do secondary data work. And so I said, I've been thinking about trying to do this flu project. Would you think about doing it? And she said, yes. So that's when we started collecting data. From that, I developed into some honors topics courses for my university, and I've hosted now, just in the last couple of years, 12 research interns, undergraduate research interns. They have presented at national meetings. They have presented on campus. I've also been faculty on 2 master's theses. Oh, and 20 research internships, excuse me. Just in the past 2 years, it's been 12, but around 20 overall. And those have produced 10 posters and podium sessions. So this has been a real avenue for getting students involved in my research. What have they done? One of the first things I had students do was collect the data, because this is what the data looks like. Our state digitized our death certificates, but when I say digitized, they only scanned them. So I have to make the database. They're PDFs, they're not OCR. So you can see how they look. Can anyone see what this person died of? It's hard to read, right? And this is the first thing my students tell me is, oh, it's too hard to read. They don't know how to read cursive anymore. They died of pneumonia, lobular pneumonia, contributory influenza. So this is actually the first person in my town who died in the flu pandemic in the fall. There's his name, Poe. He was actually reported on in the newspaper, so that's why I'm sharing his name with you now. These are so old that they're out of HIPAA, and this is not considered human subjects research because of the age of these records and the fact that these are publicly available online. You can see when he died, you can see how old he was. He was 18 years old. He was a US soldier who was recruited at the university. And then there's his date of death, October 12, 1918. So we collect all this data and we put it basically in an Excel file. And we have, we looked at over 130,000 of these records, and of that's everybody who died in the state of Missouri over that 3-year period, and about 34,500 were flu. So we did that by hand. I needed a lot of students helping me. Okay. So this is the other thing that I had them do. We've then kind of spun off a bunch of projects, is I had them go look at our newspaper. Missouri has the world's first school of journalism. And so because of that, we have a newspaper that has been digitized in our community, and they've also worked at digitizing newspapers in other parts of our state. So there's actually a really nice library of newspapers, some of them dating back to this time. So we were able to look in the newspaper for records of public health interventions like closures, influenza order, closing businesses and schools. Our university closed, but then it reopened right after that. All the schools reopened, and then they had to close again because it takes more than a couple days to actually stop a flu pandemic. So I had students doing this in a number of places, doing record searches. We ended up looking at State Board of Health records from the time, the meetings of the State Board of Health. They're all public through our archives in our state. So they did this to do some small projects. So something like that previous one that I showed you, I had a student turn into this poster where he looked at 4 different counties to see how school closures and how various other institutional closures impacted the pandemic. We can't do causality, but we can see patterns, right? So we can see, some things, we can develop some timelines. So this was one that was presented at a national meetings poster session. I had students do projects on specific populations. I found a really neat cache of hospital records in our historical society in town, and were able to have somebody who happened to be a medical coder who was finishing her degree. I think you would call them maybe your sandwich students, She came back to school to finish her degree, and she already knew how to do medical coding, so she did censuses for me, and she did length of stay calculations for me from this set of billing records. And so we presented this as a poster, and then in a more final version as a talk at national meetings. I've then spun off, and I'm interested in other respiratory diseases and the effect of the 1918 pandemic on other respiratory diseases. So this is another student who did a look at whooping cough. Whooping cough virtually disappeared during the flu pandemic. There was almost no deaths of whooping cough. Whether that's recording error or whether that's truly that it didn't spread, that's very hard for me to tell. And then finally, this is my last student who did her look at diphtheria. So we're just kind of looking at the environment now, the respiratory disease environment in Missouri at this time. So we've been working really, this pipeline I have of students is made possible by the curriculum that we have at my university, where we have an internship that's required, and some students like to do research internships. And then my internship supervisor knows to call me and say, hey, Carolyn, I have another one. I have another one. Can you do another internship? And I say, I never know how to say no. So this is how this has all come about. So just to finish up, this is kind of our findings. I think one of the things this research has told me is that if you do the smallest amount of historical background or even some socioeconomic, just know your hotspots. Do a little bit of research about your communities for pandemic preparedness. It should always include that, because we know that institutions played a role in the spread of disease. How long is long enough for your NPIs, for your pandemic control measures? Clearly, people used to think 1918 flu was gone by 1919, but now we're saying no, it's into 1920. People were calling me on the phone asking for comment during the early days of COVID. How long was 1918? And I had to say, well, I hate to tell you this, but it looks like it's into 1920. And this was, the summer of 2020. And they're looking ahead and they're saying, oh no. But what did we see? It's continued. And then, of course, this is my own personal soapbox. But, context is important. Historical knowledge is important. As much as you can get of it, I think it's helpful. It may not tell you something that you can use to predict outcomes, but it does tell you ways that you can understand your community better, especially as an academic. I'm not from Missouri. I didn't know much about Missouri, but I chose to work in Missouri, and to educate myself about Missouri, now I know much more about the community where my students are coming from, where I'm living, where my work is centered on. So thank you for this. This is, I'm kind of reusing a little bit of slides, but I want to thank you a lot for having me here to share this. I want to acknowledge just some. I couldn't even fit all of my undergraduate student research interns on here, but these are the graduate students and the people who have graduated. All of my co-researchers and research group. I really want to thank you for inviting me to be here.
Thank you. Very, very insightful. And of course, we're familiar with the closing and opening and closing again. And with that, we did quite a bit of that here as well. So this is all familiar. Dr. Kabak, are you ready to introduce us to the next speaker? We should take some questions first. Let's do it after. They want us to do it after. Yeah. Okay? All right.
All right, thank you very much. So we now would call on Prof. Takan to introduce the second speaker. Thank you.
Dean of OIP, I thank you very much for this opportunity to introduce our next speaker. Our next speaker is Prof. Wilson Majee. He has an MBA, MPH, and a PhD. He is an associate professor with the University of Missouri, Department of Health Sciences and Public Health. His areas of research interest are exploring, identifying, and implementing place-based approaches to health and well-being of those living in resource-limited communities. Also, the interdisciplinary nexus of community leadership development, community engagement, and health promotion research and practice. Also, knowledge and practice gaps using the socio-ecological approach to multi-level individual, family, place-based factors affecting health and well-being. In terms of his collaboration, he is with the University of Western Cape, the Cape Peninsula University of Technology, Stellenbosch University, Stendian University, all in South Africa, and also several local community organizations in Missouri and South Africa. He serves as an extraordinary professor at the University of Western Cape, where he is currently a Fulbright scholar. In addition to his work at Missouri University, prior to joining that university, he worked as the MU Extension's Community Development Specialist in rural Missouri, where he partnered with county commissioners, church leaders, school administrators, health departments, and community action agencies in developing and implementing programs to improve the health and well-being of community members. Having grown in rural Zimbabwe with limited access to quality education, he has a strong passion for empowering vulnerable youth through educational and economic opportunities. Dear audience, if you came to this hall with your hands, can we give it to him as he presents?
My PowerPoint here. Okay. Okay, go to the PowerPoint. Okay, so which one? Thank you very much for the wonderful introduction. And I also wanted to thank Prof. One for the invitation or for the relationship that we've had since 2014, 2015. I also want to thank Prof. Kaba for the work we have been doing, preparing for us to come, and Dominica for helping with the process for visa application, Professor Amuna for wonderful, delicious lunch. So my talk is a story. I'm basically going to talk about myself in terms of how I moved from Zimbabwe to the US, the work I do in the States, and where I am now. So I emphasize my story for two reasons. It's a story that is decorated with a lot of poverty in it and a lot of blessings. So at times when I tell that story, I believe I'll motivate others that are also at the point where I was when I was done with when I was in high school or growing up in rural Zimbabwe. So I'm not going to go through this whole slide, but I'm going to just touch on things. I was born in rural Zimbabwe. I'm the last in a family of 6, 4 girls, 2 boys. My sisters were brilliant, intelligent, but they were never given an opportunity to go to beyond grade 7. So they did primary education. The family was poor. They said we cannot invest in a girl child. They are going to get married. My brother was able to be sent up to O level, and he's the one who sponsored me to go to school. I'm the first one to go to A level. We're talking about A level earlier on. I was the first one to go to university in Zimbabwe. As you can see here, this is my years in Zimbabwe. Then after that, I was the first one to go to the States for my PhD. So now I serve as an associate professor at the University of Missouri. I'm an extraordinary professor at the UWC, and I'm also a Fulbright scholar at UWC. And I've been serving on several NPOs, non-profit organizations for a long time. Since 2006, I've been sitting on boards for non-profit organizations. So like I said, my story is going to be the story of my research. So I'm just going to talk about research and focusing a lot on where I started and where I am now. So let's start with that story. So basically we think of research as a systematic, organized process that goes through sequential steps that is designed to develop or contribute to generalizable or transferable information. And research will help us to understand, explore, explain community issues, whether it's from an economic perspective, or it's a political, or it's a health issue. So we do research for a variety of reasons. One is this, to provide, to explore and understand issues that we face as a society. And we do that from a population health perspective, from an environmental health perspective, from an animal perspective. It also facilitates the interpretation and evaluation of literature in relation to specific issues. Dr. Orbann talked about how she goes into literature, try to understand things that happened way back 1918 to 1920. Also, research helps us as community developers and other professionals to enhance our skills and career and improve people's health in the process. So my story is, when I finished my PhD, my first position was what we call a non-tenure track position. I worked as a community development specialist for in rural Missouri, covering 7 counties in some of the poorest regions in Missouri, where I did programming, like I would talk to researchers at the main campus, develop a program with them, then go and educate community members on those programs. One of those area is community leadership development. That's one of my area that I focused on a lot. We also worked on building collaborations with the commissioners, health departments, and other extension professionals. We, again, because I was coming with a PhD, most of the people I was working with were master's level. So I started encouraging extension workers to think about publishing. So we started working together in terms of, okay, where do we send our work? We started identifying journals that in academia are not considered journals with high impact factor. I'll talk about the impact factor later on. So we started the work we're doing as a community development practitioners. We started identifying journals that we could publish in and speak to that audience. So like a journal of community practice is used a lot by community developers. Community development is another journal. Again, the audience is mostly people working at the community level, promoting health or addressing community issues. Then the journal of extension, again, is a journal that is targeted a lot by people working in extension. I don't know the equivalence of extension here in Ghana, but I think most countries, they have that arm where there are people working for the government, but doing different programs, whether it's agricultural or it's business development or it's health, but they're employed by the government. So this journal is also used a lot by those people. So my time in extension was, apart from working as a community development specialist, I started thinking about how do I then publish the work we are doing. I started growing that interest and that desire to say, I can't just stop at programming. I want this information to go out and be used by other practitioners. These are just examples of some of the publications that I did as a non-tenure track faculty in extension. So again, this is speaking to the same journals that I have already highlighted. Community development, journal of extension, this is a community development. Again, early in my career, I started thinking about how do I get my work out so that others can use that work. So now I moved on to, after 4 years in extension, I was hired as a tenure track faculty at the University of Missouri, where research was now my main job, so to speak, the role that I was playing at that level. The challenge I faced then is my PhD was in development studies, a program that was meant to work in developing communities, doing community engagement, doing community development. So coming to health sciences and public health with that degree was like a mismatch, like I was like an outlier, or it was not home for me because I was coming more from a practitioner, and most of my colleagues were people who were already publishing and they understood, they had a specific area they were focusing on. My background I was a community development specialist. I work with community issues, irrespective of what type of a community issue it is, because I'm trying to improve the health of community members in their communities. So what I then did was to try and think, how best can I switch my work so that it speaks to the needs of the department and the needs of the university as a researcher. So that's when I identified my interest in the intersection of community leadership development and health promotion. So I started to look at things like youth risk behaviors. How do we engage youth that are disengaged and promote their health, so that I can continue to do the work I love to do in terms of engaging community members and improving their health. So in that process, again, I realized that I could not do this alone. I started thinking about building collaboration, working with others the work that related to my work. I identified a lot of collaborators, like at the University of Western Cape in South Africa. These are some of the professors that I have worked with. And it was Professor Yost that connected me with Prof. One. When I was doing my work in South Africa, I met Prof. One in 2014, 2015 in Cape Town. I have collaborators at Stellenbosch University, at the University of Missouri. These are all people I work with in different departments, because if research is supposed to improve the health of communities, it means any researcher is somehow going to work with a community or will need a community. So I found that space for me, that I'm already working in the community. This is my area of specialty. So I started engaging others that were working in other areas, so that we could do more community engagement and community improvement, health promotion work. I also identified a lot of organizations that work at the community level, so that I could do my research with community leaders or community members as experts in their communities. So again, you can see this is a big wind farm in Eastern Cape in South Africa. This is Red Cross. This is Catholic Charities. I'm sure they are all over the world, but I was working with the one in South Africa. The local health departments, I work with those a lot. So that again, I continue to build partnerships between the university researchers and community organizations. And I started to improve my publications. The earlier publications were in journals that were for non-tenure track people. These ones are more academic, very academic journals, and they start to have impact factor. Like this one, I think is a 2.6 impact factor. Global health promotion, again, is a 2.6 impact factor. This one is still yet to get an impact factor. So I started to progress in terms of where I was publishing my work, so that I could meet the requirements for tenure at my university. Impact factor that I'm talking about, you see, these journals here are very low impact factor. I think this one is 1 point something, I don't remember. This one is 0.6. This one is no impact factor. Again, my idea was to at least publish something that do not publish at all. So I started with in this area. Then I moved on from mid-level impact factors. These are the journals that I've already explained. Now most of my work is in higher impact factor journals. This is a 4.6 journal. Journal that I'm publishing in, and I have one article that has been accepted, but we are still working with some changes, and the impact factor is about almost 8, which is very high in my field. Again, these are some of the papers that went into a low impact factor journals and mid-level impact factor. So again, these are just some of the articles, papers that I've published. Again, the idea here is to move from low impact factor to high impact factor, this is a 2023 paper that came in a 4.6 impact factor journal. So I want to move on to the tech. I just gave you some of the work that I've done and how I've progressed as a researcher. So what do we take away from this, from my experience? The first thing is, it is very important, if you are a researcher, to build, to initiate, or to have the initiative to build collaborations. Research, you cannot do it alone. You really have to be well connected, think about who can I partner with, who can I work with, so that you can have more productivity. So think in terms of your grant applications. you can collaborate with people at the grant application level, grant proposal, find a way to be useful in a team in terms of your ideas for research. You can also collaborate in just doing the research. You can also collaborate at the community level, like I said, with the community organizations. Some of my publications are on issues that were identified by community members. They said, we are having this issue. Then I come in as a researcher and say, okay, how do we frame your issue as a research question so that we can collect data with you and publish? Again, these are examples of some of the organizations that I partner with, and most of all these are active partners that I have on my CV and in my work. The second, sorry. So this is again connect. The second point is connect your work to relevant current events. COVID-19 was a big opportunity for publications. Most people went for it and say, okay, because it affected everyone in different ways. So you should have had your own piece of the COVID-19 in terms of your publications. So what I did in my case is because universities were closed and we have a lot of international students, PhD international students in my school, so I called one student and said, can we form a group here? The university is closed. How can I support you to continue to be productive? We ended up having like 6 PhD students. I think 3 from Nigeria, 2 from Sierra Leone, 1 from Ghana. Then we said, okay, let's come up with a topic. Let's do some research whilst the university is closed. Let's think about things that we can do. Then I supported them. They came up with their own idea. They wanted to understand the experiences of African international graduate students at the University of Missouri. So they did their interviews, we did the analysis, and they've already published. This is one paper that they've published. This is another one they've published. So I took that initiative to reach out to students and say, let's continue to be productive. Then we did this. So the point I'm making is, if there is something that is happening current and it's affecting the world, or even your nation, or even just your community, tap into that and find a way to come up with questions that are going to help the community. The other thing that I did around COVID-19 was, again, because it was affecting a lot of African Americans. So I went into the community just to visit and talk. How are people taking recommendations for vaccines? What is happening? Are people getting access to healthcare services? Then one community member told me that, there are issues in terms of discriminatory tendencies when they go to the hospital. Some are complaining. So I said, okay, how can we do a study around that? So they helped me to come up with, to do some interviews with a lot of community members in that community in Colombia. Then we ended up doing a publication again. I think it's I don't know if I have it here. The past is present. Maybe I did not include it. This is another one. It's earlier. The past is present. Yeah, this one here is with community members. So I did, I think, 3 publications from that small study. It was just like 15 interviews, but we ended up doing several publications, and it went into a journal that is like 2-point-something impact factor. So that's, again, the idea is be thinking, don't just be like focus on your specific area, but be thinking in terms of, okay, how does this connect to my work? Then the third issue again here is involve students in your research. I've already touched on this. This is the group that I started, and again, they've already started publishing their work. I'm still working with them. It's growing every year as new students come into the school. Some are reaching out to me on their own that, we heard about your lab. Can we join your lab? And some of them are quantitative. I'm a qualitative researcher. So in the end, I have to invite other faculty members who are quantitative to give that guidance to these students who want to use mixed methods. So the key thing is you work with your students. When we did the tour of the other campus yesterday, we saw faculty members doing experiments with students. Use that data to get where it can be published. Do not pass on opportunities for book chapters. That's another area where I work a little bit. They are not for promotion in the US or at the University of Missouri. Book chapters are not considered very, very highly. So we don't do much of them, but again, it builds your CV. It helps you to connect with other people. So at times you get invitation, like this one is an invitation that came from South Africa. They wanted me to do a book chapter here. Then I reached out to my collaborator at the University of Western Cape. Then we did that one. So it's again opportunities that come, try to say, okay, maybe I can do this I'll pass, but don't pass all book chapter opportunities. Serve as a reviewer, guest editor or editorial board in your profession. We all are members of our professional associations. So make sure that you don't just go to a conference and be done. Either be a board member or something, do something with your profession so that you get better connected with others. This is a invitation that came from that journal. I said it's 4.6 impact factor. They send us an invitation that you want to be the guest editors on a community-based health promotion. So I'm also extending that invitation. If there are faculty members here who are interested in publishing, submit your abstract. I'm serving as a guest editor with my colleague at UWC, and the abstracts are going to be due January 2024. So we still have time to be thinking about it. If you have any research that you are doing at the community level around health promotion, this is an opportunity to think about and see if you can submit for publication. Apply for grants. We cannot overemphasize this. It is really important for you if you want to do research, if you want to do good research, make sure that you are constantly applying, coming up with ideas, apply for grants, and serve on different roles. You can be the PI or co-PI, or you can be just one of the PIs. You can serve as a consultant or as a key personnel. At least if you're on a grant, it helps again to build your CV and for you increase your visibility. You can apply internal funding at the university level, or it can be funding at the national level, like in Ghana. Maybe there are some departments that provide funding. Try to spread your wings, so to speak. Try to identify different sources of funding so that you can apply for funding in those areas. Participate and present at conferences in your field. Again, I've traveled a lot because of conferences, to present in conferences. I'm actually going to Australia to present at an international conference in June. And I've been blessed to be able to do all that traveling out of the work that I'm already doing. I think that will take us to the end.
Professor Majee, thank you so much. I'm particularly appreciative of the community development approach, which is where the relevance of the research will come in. So we appreciate all the work that you're doing to impact the communities in which you are involved. So thank you for that. So at this point, we're going to open the floor so that those of you who have some questions or are seeking some feedback can get it from both authors. So if you have anything that you need clarification on, or you want to comment, pass a comment, what have you, please raise your hand and we will bring you the mic. Anyone?
Mine is not a question, but a comment. And I want to say how much I'm very impressed about your community involvement. And your upbringing did have a lot of impact. What you did was effortlessly. So you could go into a community, look around, and see the challenges in that community and turn it into research. And I think it's been a lesson and a food for thought for me and then my colleagues. Thank you.
That's his hand back. Anyone online? Can you identify them, because I can't really make them out? Who? Richard. Richard, via Zoom, is your hand up? Greg. It's rather Greg. Go ahead, Greg.
Yeah, thank you very much. Thanks to all the presenters. My question goes to the first presenter. Looking at the 1918 flu compared to the COVID-19, which happens in 2020, thereabout. I want to find out whether the rate of spread at that time, and also that's for the flu, and then the rate, that's the global spread because it's a pandemic. What is the difference in the rates? Are they having similarities? Looking at those days in 18th, communication or transportation might not be so fast, but then I want to find out how is it like? Did they have any indicator like that look at the spread level of how fast it spread across the globe?
Thank you for that question. I don't have specific quantitative data on the rates of spread, but I believe that COVID spread more quickly than 1918, largely because, like you said, transportation was quite different. And we know that the patterns of who was bringing, like in the U.S., often the first case to come into a community was somebody who was high income, who had been returning from a European vacation. This was the truth in several communities in our state, in other Midwestern states. It was somebody coming home from Christmas skiing in the Alps, something like that. Whereas 1918 flu was more related to that World War I movement, not just the troops, but also medical professionals moving around and other people moving to go visit people in training. The predominant form of transportation in my state in 1918 would have been, there were trains, passenger trains, some of them were closed down, some automobiles, and walking or animal-driven transport. I didn't have time to show you on the presentation, but the mortality peaks, and like I said, I don't have case data because of data quality, but the mortality peaks are in every single urban center within a 2-week period. So there was really no, that I could discern from mortality, no clear geographic spread. So I couldn't tell if it came in from the east or from the west. The data quality wasn't precise enough.
Let me just add that there was a certain pattern of the 1918 flu spread which also followed trade routes. So, for example, in Ghana, it spread along trade routes from, indeed, two. One is, as you said, the returning troops. They actually traveled by boat, by ship. And so wherever they docked along the coast, it started from the coastal areas. So in Ghana, in those days, in the Gold Coast, it was from Sierra Leone, the port of Sierra Leone, to Cape Coast. And then from Cape Coast, it then moved through Takoradi to Accra. And then from Accra, it went inland through Koforidua to Kumasi to Tamale, because those were trade routes. So it's a very interesting pattern of distribution. And so you would expect that the spread across the world would have been a bit slower because of the time it takes to move from one end to the other. And for now, you notice that when people went on cruise ships, there was a spread. And then people flew by air, as you said, and those who could afford it, and then there was a spread. And then came the community spread once it had landed inland. And that was where then the question of the public health measures became critically important. Thank you.
Dr. Kaba.
Thank you very much for those two interesting presentations, Prof. Majee, Prof. Orbann. Very interesting indeed. My question, or more or less a comment, goes to Prof. Majee. It has to do with the prospects for students who complete their, let's say, their first degrees from less endowed environments like ours. Somebody does the first degree, wants to do the master's, let's say in Missouri, has all the qualifications, applies, gets admission, no scholarship. And if you're not careful, that individual just perishes around with that talent. And I can speak of one student who did public health nursing from UHAS here, completed. She's doing her service at, I think, Cape Coast Teaching Hospital. And a few days ago, she got to me that she had applied to University of Missouri and needed a recommendation letter from me. So when you were coming, I actually told her to join. I don't know if she's online. She's called Sandra. Sandra, if you can hear us, I think this is an opportunity. You may want to find out which one of them will be willing to give you not a scholarship, but a recommendation or something. I mean, expressing the willingness to supervise you when you're around and all of that. And then maybe to show you the way by way of scholarship opportunities. Thank you very much.
I can respond to that maybe in two ways. The first is I would encourage students to not to fear, but to apply. I receive a lot of emails from students in the Arab world, in Africa, everywhere, just asking, I'm doing this, do you have an opportunity? At times they send their CVs, I look through and say, this is interesting. Then maybe I forward it to the admissions, the person who is responsible for admitting graduate students in our school. So it's always a good thing to look through what the professors are doing. If things are lying, send an email, ask. In the case of the one who has already applied to our MPH program, if they want a recommendation that I've been here to Hohoi. So I can support them. I can at least facilitate the process for the papers to move.
So Sandra, you heard that, the original Sandra, not everybody whose name is going to change to Sandra on the screen. The original Sandra, you know yourself. Is there anybody else, either in here or online, who has a question?
Thank you for the opportunity. I'm Emmanuel Menu. My question goes to Prof. Orbann. Actually, from the presentation, it was clear that mortality rates were actually high within the poorer counties of Missouri, both for the 1918 flu and COVID-19. And you made mention of some resources being delivered to those areas to actually mitigate or to try to improve upon the socioeconomic status of the people. Yet they are still poor and dying from infectious diseases. Could it be that there's some kind of resistance or mistrust in terms of the services that are being delivered to them, leading to such mortalities, even especially with COVID-19, or they were just not adequate?
Yes, thank you for that question, because that's really, really important. So I will say that the counties, especially the Boot Heel, which is of particular concern in our state, have had these disparities in outcomes of all types for a really long time. They were the center of malaria transmission in our state until the early 1920s or the early 1930s. They had some high rates of trachoma. They had high rates of nutritional deficiencies. They had all these things that were, the public health at the time was there trying to chip away and made some gains. But the real lack of kind of holistic social response is what has really kept those disparities in place. So the things that have been deployed have been things like state grants for health interventions. And sometimes those are multi-year and sometimes they're one-off. But what they don't have is good prospects for economic development. They don't have high educational outcomes and the support that the communities need for educational outcomes. They don't have high rates of college attendance. And in fact, they sometimes have some forms of state neglect. So for example, recently a predominantly black African-American town was actually destroyed when a levee was intentionally breached in order to reduce flood stage on the Mississippi River. And the authorities made that choice in order to prevent flooding downriver. But that was a choice that reflected a disparity in attention to the communities in that area. And so I think that's right. I think it's a matter of, yes, health interventions help, but they can't be the only thing because they don't solve the real problem.
Do we have anyone else? Anyone online? We don't have anyone online. Okay. Does anyone from Campbell have any question in general for those of us who are here? Or any comment you want to pass? Okay. Fantastic. There's another hand here as well.
So my question was for the first presenter, and I was wondering if you would be able to elaborate just a little bit more on one of these side posters that one of your students presented on about the impact of school closures during these pandemics and if they were effective or not.
Thanks for that question. So we looked at school closures in a number of counties, and we found a couple of things for sure. One is that school closures were frequent. They're frequent even outside of pandemic years. Even in regular flu seasons in Missouri, schools routinely close because of absenteeism. So one thing that I could communicate in a public way was that, you know, people are feeling very afraid when their schools close down, but this is something that's actually quite common. It just doesn't happen to the whole district. So this is the difference between, say, flu 1918 and COVID, was whole districts were closing down as opposed to a normal flu season when you might have one school closing for a week. Whether or not they were effective is hard to say. Because I'm working with mortality data, I'm on a lag, right? Because flu cases are going to precede mortality by about a week or two. So what it looks like is school closures are happening in general before a really major peak in mortality, which indicates that they're happening during a widespread outbreak. So I don't have the case numbers, but just if we think of mortality as a lagging indicator, we know that the cases have to be quite extreme before the peak in mortality. So that's about the best inference I can make. I don't think that they necessarily prevent mortality. I think in fact most times they're ending up being used as almost an outcome of widespread disease spread in communities. That's different from COVID when they were used as a prevention tool. And whether or not they're effective in COVID is really hard to say. I think it depends on the local environment. I will just say that Boone County, Missouri, where my town is, had pretty low COVID transmission until about the end of July 2020, which is when our university came back. So, you know, we had very, so I think depending on the kind of community, they can be effective.
My name is Peter. I was from Campbell University. I have two questions, one for the first presenter and the other one for the second presenter. For the first presenter, this is a follow-up question to a question asked earlier about trust for healthcare providers and healthcare professionals in general, because both the Spanish flu and the COVID-19 seem to have affected minorities more. Have you explored, these research violations that were foundations of all the IRB issues and research protections that we have today? How those might still be playing a role in, the residents' trust for this, healthcare providers. That could still be an issue, in many parts of the United States. The second question for Majee is about the challenges that you face in engaging the community. Community engagement not an easy task. So what are some of your advices and or the challenges you face engaging your communities?
So in 1918, I will say in Missouri, there's no record of any mask hesitancy or treatment hesitancy. We did never get a vaccine, but treatment hesitancy. And that's largely because the flu effort was folded into the rhetoric about World War I. And so this is a very patriotic state. This is the middle of the heartland, we call it. People were proud to send their children off to the war effort. They were proud to buy war bonds. They just folded that rhetoric together. And so really there was not much difference. In terms of vulnerable communities, healthcare was segregated at this time. It was fully legal to not see patients who were not white. And so the records that I have, which are mostly created by the state, there are big holes. There are big holes in those records because you have this kind of side community who is disenfranchised from services. And so this is part of a problem, so I have not fully addressed that in terms of finding those data sources. That's a real challenge. But this was a time, this was before the Social Security Act, so that act actually had an impact on people filing death certificates because of Social Security benefits. So the filing of death certificates does have a lot of holes because of federal oversight and because of other things happening at the federal level. So I think you can't see the evidence of lack of trust, but also the communities that kind of you're implying here that would be most affected, they're also kind of largely missing from the resources I have.
Thank you. I think I want to add a little bit to the first question that he asked for Dr. Orbann to address. One of the papers that I tried to highlight when I was presenting is titled The Past is So Present, speaks a lot about vaccine hesitance, and it's all about mistrust between the communities and the government, mistrust between communities and healthcare providers. So in there we talk a lot, or we provide evidence from community African Americans speaking about the discrimination that they experienced when they went to the hospital. I can recall one older man saying he had tested positive for COVID. He went to the hospital, hospital. He went to the hospital first time with his wife. Both of them had tested positive. He was returned home, said go, I think he was given some painkillers. He went, he came back the second time. They sent him back. The third time, another doctor saw him, and he said, we made a mistake the first time. We were supposed to be in hospital. Or this time, I think it was already after like 4 or 5 days, and his condition was already deteriorating. So that mistrust, I think, is very, very live in African American communities, that we still feel we don't trust the government because of the experiments that were done, Tuskegee experiments that were done in the past. We still feel like there is something hidden in vaccines, so that they want to destroy or to affect us as a minority population. Then moving on to your question, the question that you posed to me about challenges in terms of engaging communities. Earlier on I said I first worked there as a community development specialist in rural Missouri. In that town of about 3,000 people, I was the only black person. And I can recall a lot of times kids would come out of the windows, call their parents. There's a black guy in the parking lot. So they would do that. But the experience I got from that is doing community work is a labor of love. I loved what I was doing. I continued doing that until some key people in the community who initially did not embrace my presence or my coming into that community started seeing that I was there to build bridges, not to break bridges. They started seeing that I was involving myself in their community. It can be church event, it can be agricultural fair. I was everywhere. They started seeing that I was there for the reason of wanting to improve the health of community members. Then they started to buy in to what I was sent to do by the university. So it takes time to be able to engage a community, especially if you are a minority in a community. But when I started working in South Africa, it was totally different. I just went into a community. It was like just the way I felt here, that it's like, I've been here like since Adam, but this is my first time here, right? So I think community engagement, it depends on the community. You need to be creative, you need to be innovative in terms of, okay, how do I then engage with this population? What do I use? Who do I go to? Because at times you have to use key people who are already in the community, who can connect you with others. Like in rural Missouri, I had 2 pastors that helped me a lot. Oh, do you want to go to this event? Let's go together. Then they started introducing me. So the society in the end ended up accepting me and accepting the work that I was doing.
Thank you. Thank you. I think that for most people that grew up in Ghana and maybe have not been exposed to a system where maybe race plays a factor, it's kind of hard to comprehend where the parallels might be in that system compared to here. But I think that at the end of the day, it boils down to getting buy-in from the communities that you're trying to work with, building trust both ways, you know, them trusting you and you also trusting that your back is covered, that when you go into those communities, people will accept you and give you the necessary grace to be able to come and help them. Because I think that your work is to help people. Most healthcare workers, researchers, all of that, you're trying to find ways to better the environment. And so we applaud all of you that continue to do this kind of work. UHAS is a community-centered university. This is one of the hallmarks of the training that we give our students here, is that we're community-focused, and you know, service and care is one of the 4 core pillars or ethos upon which the university is founded. And so that differentiates us from most other universities out there. And so I'm liking what I'm hearing, and this is the whole purpose, I feel. I mean, of course, compared to the rest of you in this room here, my expertise is in being a patient. So, like, I'm a very good patient, you know? But, you know, when you are providing care, it is for those of us who are on the receiving end to be able to benefit. And so, thank you, all of you, the 2 visitors, and those of you who are here doing all this good work. Those of us who are benefiting, we appreciate you, even if we don't say it enough times. So kudos to you. Please keep up the good work. I think that we are done with the question and answer session. And at this point, I will call upon Professor Amuna to give us his closing remarks.
Thank you. Thank you very much, Maria. First of all, let me thank our 2 speakers here, Caroline and Wilson. I was excited when I heard you were coming here, and for the right reasons. And I think our colleagues from Campbell yesterday, when we mentioned to them about joining this, we were all quite excited. And I think it wasn't for not a good reason. I don't want to, you know, give 2 lectures. So I'm going to try my best to just remind us about the key highlights of your presentations. First of all, Caroline, you gave a historical perspective of pandemics, using the 1918 flu pandemic and COVID-19 as examples. What I thought was interesting about your work and your approach, and how it related to how you were able to get some grant funding, was the fact that because of your background in anthropology and your interest in historical records, you started exploring the 1918 flu out of interest And I think the second speaker also talked about the fact that you have to be interested in issues, you have to engage in the community and look for low-hanging fruits, opportunities for doing research. And so in doing that, initially I know you did not have funding to support that work. And that was in 2017. Lo and behold, at the end of 2019, we had COVID. And suddenly, there was a lot of interest in the work. So I think for me, the take home here is that we should be passionate about what we do, regardless of whether somebody is giving us money to do it or not. And we should also relate what we are doing to relevance in terms of its importance to our community, to our institution, and to our students. The other thing that I take away from both presentations is the fact that Caroline mentioned the fact that we should always involve our students in the research that we do. And that is something that I think for us here at UHAS and in the Binka School of Public Health, it resonates. Because if you look at the publications of our faculty here, you find that a lot of the publications are co-authored with students. And in my own career, Prof. Zotto will tell you that I always make sure that the student's name came first, because it is so important. And sometimes you find that when you brainstorm with the students and you start working with them, I mean, the ideas that come forth and what it can lead to is great. So those are very important highlights that I got. I also want to highlight on a few other things that were mentioned here in terms of taking initiatives and building collaborations. These are critical, and I think for those of us from Campbell, from UHAS, from Missouri, we are doing exactly that, to build collaborations, partnerships, to think together, and to break through the barriers, some of which have been mentioned here, that we are colorblind, we are race blind, we are ethnic blind, we are religious blind, and all the rest of the things that can act as barriers, but rather to seek ways to build bridges rather than to break them, as Wilson told us. I think, Wilson, you used your own life journey as a way of teaching us about how we as an institution can actually develop a strong research and publication track by relating to your early beginnings and the challenges, and then as you went along, even your choice of subjects going into community development, because you felt that there was a need for you to actually do something to make a change. And then in the process, you did your PhD, and then you got working in the communities, linked to the university, and then you started slow. I like your approach. That is that you started your publications in areas regardless of impact factor. Because the idea was, okay, let me go in there and see whether they will accept my paper or not. That doesn't mean that the quality of your paper was poor, except that that journal, perhaps at the time, may not have had a good impact factor. One thing I do know is that, indeed, over years, good quality papers that were published in hitherto low income factor journals actually help to propel those journals. Because your impact factor depends on the number of people who are actually accessing and citing the work that people are publishing in that journal. And then you migrated to the mid-level and then now to the high level. I think that is a lesson for those of us, especially our young scientists and students in UHAS, that we should actually, bring this and brainstorm around this. Because in this university, we are very, very keen on, is your paper in Scopus? Are you listed in Scopus? Are you on PubMed? And I think even though that is a good thing, we should not just dwell on that. We should look at all the different avenues. And when we work that way, it will help us a great deal. I know that we have initiated some writing skills, laboratories and things like that. And we'll continue to do that. And I think with our partnership with you, we might just tap into some of your experiences and get you involved in some of that. I think this is great. You also talked about the need to look for grants and write for grants. Just this morning, a colleague of mine that we had put in a grant application came to see me and said, "Oh, have you seen the email they sent us?" And I said, "No, I haven't actually sent it." He said, "Well, he got the email, but he wasn't sure whether it was, so I should check." So I went with him to my office. And when we checked, we had been rejected. The thing is that they are only supporting 4 projects in Africa. And they cannot give more than 1 in a country. So I think I said to him, what they should have told us was that we should collaborate across countries and rather put in bits of about 6 countries and then they would have looked at it and perhaps everybody would have got in. Because it's no use you telling me, "Oh, and your application was nice," and all that. Because I know that University of Cape Coast and us in Ghana applied. So I quickly contacted my link in UCC and said, "By the way, have you received any correspondence in relation to this?" Just to be sure that Ghana, whether we got it or not. And then they say, "Oh, they have other programs and they are going to contact us anyway." But you never give up. Those of you who've been involved in grants know that, you win 1 out of 10. And so I think on that note, I want to once again thank you all and thank our 2 speakers. I know Vice Chancellor was still on. I don't know if she wants to say a few words. Otherwise, I want to, on behalf of the Vice Chancellor, Professor Lydia Ziato, the registrar, the senior management of the university, I want to really thank you. And I want to thank our audience. I know some of our students joined us late because they were busy doing their measurements when they were training, actually. They are being trained on how to take accurate measurements of weight and height. Believe you me, there's a lot of error. And they are being trained properly. And they joined us. So I want to thank you all for your audience and for the wonderful presentations. You've given us a lot of food for thought. And I'm sure we will leave here and continue the discussion. So thank you very much.
Oh, Prof, you want to stay with me and let's do the presentation. Dr. Kaba, you want to join us? Mr. Gato, we need you to hold the mic.
Some few words. Okay. Per our tradition as a university that cherishes our guests, we want to show this token of appreciation on behalf of the Vice Chancellor, senior management, and of course on behalf of the Binka School of Public Health. Just for you to take this back to Missouri and show to them that this is the beauty of UHAS and Ghana. So we hope you appreciate it.
Okay. Yeah. All right. So, Dr. Caroline, if you would step forward, please. Yes, so we have these goodies for you. There are some, yes. A sash, yes. Yeah. And, yes. And those are the yes. Branded scarf from UHAS.
No one can borrow it.
And then, yes, this is from the Binka School of Public Health. Yes, yes. Yes. Yes, and then Dr. Wilson, Majee, please. Yeah. So we have a sash with your name engraved on it. Yeah. And then a UHAS branded tie. Oh, yes.
Yes.
And
You're quite welcome.
okay. So if we can take a photo. Yeah, yeah, yeah. Oh, yes. Right.
After the picture, then.
All right.
Yes. Yes, you, yeah.
Okay, great.
Yes. So the Missouri group, they also have a token for us. And I thought, yeah, they should present it to the dean, I think. It's for, so she can do it.
Let's ready?
Okay, this is just to say we are Mizzou, and we are trying to make sure that when we are gone, we leave our footsteps here, so that you remember, I mean, our partnership, and we hope you've been able to enjoy the little gifts that are in here. It's mostly for students, right? You're going to give for students, yeah, yeah.
I think just to be sure they are not little bumps.
And
so they are earbuds and then
Some pens, some pencils.
So you can remember our name.
Yeah.
Yes.
Okay. Thank you. Thank you very much.
Thank you.
Okay. So on that note, we have come to the end of this afternoon's engagement. Look at that. We have a full room. I hardly turned my back, but what a pleasant surprise. And so we are officially done, and I can also say with confidence that this was a very successful event. All right. Once we're done, we can meet outside to have some snacks and also to take some lovely pictures. It's beautiful out. We shouldn't miss the opportunity. Thank you so much for coming, everyone. Pictures before snacks. Okay. All right.